Hi, I am Ajit Virkud, Professor of Obstetrics and Gynecology from Mumbai.
Hello, citizens of the internet. Today I am going to talk to you about abnormal uterine bleeding. In this e-lecture, I am going to lay emphasis on dysfunctional uterine bleeding. I will cover this important topic in two parts. In the first part, I will discuss the definition, types, and causes of DUB. In the second part, I will dwell upon the diagnosis and management of DUB. The management is based on ACOG treatment guidelines for abnormal uterine bleeding. About 1 to 2% of women with improperly managed anovulatory AUB eventually may develop endometrial cancer. For me, this topic is particularly important because dysfunctional uterine bleeding patients are exposed to unnecessary surgical intervention such as repeated uterine curettage or hysterectomy before adequate workup and a trial of medical therapy can be completed. Abnormal uterine bleeding is defined as any deviation from normal frequency, which is 21 to 35 days, duration, which is 3 to 7 days, or amount of menstruation, that is 30 to 80 ml, in women of reproductive age. In other words, menstrual bleeding that is unpredictable, abnormally heavy, or abnormal in timing is abnormal uterine bleeding. AUB is of two types. The first type is called acute emergent abnormal uterine bleeding, which is characterized by significant blood loss that results in hypovolemia, that is hypertension and tachycardia, or hypovolemic shock. The other type is menstrual abnormality that occurs slowly over a period of time, usually greater than 6 months, which is referred to as chronic abnormal uterine bleeding. This is more common. About 10 to 20% of all women attending the gynecological OPD do so for this complaint. Virtually every woman will at some point in her lifetime experience episodes of bleeding that will be perceived as abnormal. It is interesting to note that women of today experience about 10 times more menstrual cycles than their ancestors did. This is because of effective contraception and no pregnancy or no lactational amenorrhea. AUB can occur in women of any age group. About 20% of affected individuals are in the adolescent age group, and 50% of the affected individuals are aged 40 to 50 years, and the remaining 30% are in the reproductive age group. AUB has various causes such as pelvic pathology, also known as structural causes, polycystic ovarian syndrome, pregnancy-related conditions like miscarriage, ectopic pregnancy, gestational trophoblastic disease, coagulation and hematological problems, medical problems like thyroid, hepatic or renal dysfunction, iatrogenic, and last but not the least, dysfunctional uterine bleeding. This busy table illustrates the secondary causes of abnormal uterine bleeding, which should be ruled out before making a diagnosis of dysfunctional uterine bleeding. I'm not going to elaborate on each cause. Before I embark on the topic, I want you to know the terminologies used in menstrual abnormalities. Bleeding that occurs at normal intervals, which is 21 to 35 days, but with a heavy flow which is equal to or greater than 80 ml, or duration which is greater than or equal to 7 days, is called as menorrhagia, whereas intermenstrual bleeding is referred to as metorrhagia. Excessive menstruation along with intermenstrual bleeding is called menometorrhagia. Spotting that occurs just before ovulation, usually because of a decline in estrogen level, is called mid-cycle spotting. Bleeding due to low estrogen levels due to poor quality ovarian follicles and atrophic endometrium is called threshold bleeding. Polymenorrhea refers to bleeding at less than 21-day intervals and may be caused by a luteal phase defect. Sometimes the bleeding is so irregular and excessive that the patient cannot make out which is the menstrual period and which is the intermenstrual bleeding. This I refer to as acyclic bleeding. This is particularly seen in women with invasive carcinoma of cervix with an exophytic growth. Oligomenorrhea is a bleeding that occurs at intervals of greater than 35 days and usually is caused by a prolonged follicular phase. If bleeding occurs greater than 1 year after menopause, it is referred to as postmenopausal bleeding. Cessation of menses for 3 of her normal menstrual cycles or 6 months in the absence of pregnancy or lactation is called as secondary amenorrhea. I am mentioning them here because in a way these are also abnormal bleeding patterns. Recently, FIGO has proposed a new classification called Palm-Cohen classification. Structural causes are denoted by the acronym PALM, where P stands for polyp, A for adenomyosis, L for leiomyoma, and M for malignancy. The non-structural causes are given the acronym COHEN, where C is coagulopathy, O for ovulatory dysfunction, E for endometrial abnormalities, and I for iatrogenic causes, and N is for not classified, which is traditionally called as dysfunctional uterine bleeding. DUB is a term coined by Sutherland given to a group of menstrual disorders which are left following exclusion of all secondary causes of menorrhagia such as pregnancy or pregnancy-related disorders, medications, iatrogenic causes, obvious genital tract pathology, and systemic conditions. Being an old-timer myself, and since many of your examiners are very senior doctors, I think you should also know the older definitions of dysfunctional uterine bleeding. Kistner has defined it as abnormal uterine bleeding in the absence of palpable pelvic pathology. Another definition is abnormal uterine bleeding not due to organic gynecological disease. Abnormal uterine bleeding unassociated with tumor, inflammation, or pregnancy is the definition given by Novak. In our times, anovulatory DUB was thought to be of two types: metropathia hemorrhagica or cystic glandular hyperplasia. It is a kind of hyperthreshold bleeding and threshold bleeding. On the other hand, ovulatory DUB was called irregular ripening or irregular shedding. These terms are not used anymore. As I have referred to earlier, DUB is of two types. Anovulatory DUB is seen in 80% of cases. It is common at extremes of reproductive life when anovulatory cycles and luteal insufficiency are more prevalent. Ovulatory DUB occurs in 20% cases. It is more common in the reproductive period of life. I will compare the two types of DUB. Anovulatory DUB results from disturbance of the hypothalamo-pituitary-ovarian axis that results in irregular, prolonged, and sometimes heavy menstrual bleeding. Prolonged bleeding that occurs at irregular intervals following several months of amenorrhea is most likely to be anovulatory DUB. On the other hand, bleeding that occurs at regular intervals and is preceded by premenstrual symptoms such as breast tenderness, weight gain, mood swings, and abdominal cramping is likely to be ovulatory DUB. It includes polymenorrhea, oligomenorrhea, mid-cycle spotting, and menorrhagia. I will now describe the pathophysiology of anovulatory DUB. These patients have lost cyclical endometrial stimulation that arises from ovulatory cycle. As a result, these patients have high, constant, non-cycling estrogen levels that stimulate endometrial growth. Proliferation without periodic shedding causes the endometrium to outgrow its blood supply. The tissue breaks down and suffers from the uterus. Subsequent healing of the endometrium is irregular and dysynchronous. In adolescent girls, the hypothalamo-pituitary axis is immature. It takes long time to establish positive feedback and LH surge. Hence, most cycles are anovulatory. In first few years after puberty, till the hypothalamo-pituitary ovarian axis matures, estrogen withdrawal bleeding occurs. This results in irregular menses with prolonged excessive flow. This is known as puberty menorrhagia. This is the end of part 1 of my e-lecture on DUB. In part 2, I will talk about the diagnosis and management of DUB. For further reading on this topic and other topics in obstetrics and gynecology, refer to following books written by me. Practical Obstetrics and Gynecology, Modern Obstetrics, Modern Gynecology, Clinical Cases in Obstetrics, Questions and Answers, Clinical Cases in Gynecology, Questions and Answers, and Pelvic Reconstructive Surgery. If you have found this video useful and informative, please subscribe to my YouTube channel by clicking here.